Welcome to Medicine Handy Point. Today we will discuss taking history from a patient presenting with seizure disorder. Let's start how we'll take the history. History should be divided into three parts, uh, which will include the events which occur before the seizure activity, the events which occur during the seizure activity, and the event which occur after the seizure activity. We'll try also to differentiate different conditions which mimic seizure. These include syncope, transient ischemic attack, migraine, and non-epileptic attacks. Non-epileptic attacks are pseudo seizure, panic attacks, breath holding attacks, and hyperventilation. So these are few non-epileptic attacks which we will try to differentiate by taking proper history. So we'll start the patient. Is this the first episode, or the patient is actually a patient of epilepsy? So then we'll try to identify the precipitant for the seizures. These include bright light, flashes of light, fatigue and sleep deprivation, recent illness, alcohol withdrawal, drug withdrawal, mostly benzodiazepine, illicit drug use such as cocaine and amphetamines, and non-compliance with already uh, seizure medication. We'll ask about aura, which may be rising sensation in the epigastrium, unpleasant smell and taste, sweating, nausea, vomiting, unexplained fear or anger, then deja vu, jama vu, depersonalization, and derealization. These are few conditions which can present as an aura before the proper seizure occur. Then once we have identified the precipitant and aura, then we will ask the patient what happened. To accurately determine, sometimes we need a collateral history, which means from the nearby attendant who has seen the event, he or she, sorry, who have seen the event. So we'll ask the history, collateral history. We'll ask how long the episode lasts. Did the patient actually lost consciousness during the attack or no? Because that's important. Because if the patient has lost consciousness during the attack, it is either a generalized tonic-clonic seizure or it's a complex partial seizure. So asking about the loss of consciousness is very important. If the patient has not lost consciousness, and it is then a partial seizure, so we can attribute the partial seizure to a particular region by asking a few questions. So if the partial seizure has arise from temporal lobe, there will be lip smacking, grimacing, chewing, ineffective movements. These will be the presentation. These partial seizure may be followed by generalized seizures. So if the patient described that initially I had a lip smacking, chewing, grimacing, and then seizure occurred, so means the seizure has originated from the temporal lobe. If the partial seizure arises from the frontal lobe, usually the seizure start in one part of the body and it spreads to ipsilateral body. The patient may have some fancy posture. The patient may have problem with talking. So that means the seizure has arise from the frontal lobe. If the partial seizure had arise from parietal lobe, the patient will have some positive sensory symptoms in one side of the body and may be followed by generalized seizure. If the partial seizure has arise from occipital lobe, patient will be having visual hallucination. Generalized tonic-clonic seizure. Generalized tonic-clonic seizure, there will be stiffness of the body followed by jerking of the limb, uprolling of the eyes, cyanosis and frothing in the mouth, urinary and fecal incontinence, and loss of consciousness. So these will be the features which will be present during generalized tonic-clonic seizure. Then is the absence seizure. The patient will have a vacant look. Usually the attendant will tell you in the collateral history that the patient has vacant stare usually occur in the teenage and children. By clonic seizure, there will be involuntary movement of the parts usually in the morning. So once we have identified that the seizure is coming from particular area, in case of partial seizure, then we'll proceed that what happens after the seizure, whether the patient has any lymphaticness of the seizure, is confused in having headache, has an injury. We'll ask about the time to recovery, complete recovery, and recollection of the events. Stated symptoms of etiology. So, if the patient said that he or she had a fever, rash, and neck stiffness before the seizure, means there was meningitis leading to the seizure. If the patient reports that the patient first developed limb weakness, sensory or visual problem, means the patient first had a stroke and then followed by seizure. If patient has a postural headache, nausea, and vomiting, means some raised intracranial pressure, space occupying lesion is present in the brain leading to the seizure. If the patient has ear infection, sinuses infection, facial expression followed by seizure, means the infection has spread to the meninges and brain and has caused seizure. Then we will also ask about history of recent head trauma. That past history should always include previous head trauma, stroke, meningitis, encephalitis, and any psychiatric illnesses. Medication history should, if the patient is already epileptic and not taking medication, so we'll ask about non-compliance. Drugs which induces seizure are ciprofloxacin, lithium, imipramine, clozapine, and haloperidol. They decrease the seizure threshold and can cause seizure. Those who are prone to seizure. Illicit drugs used such as cocaine and amphetamines can cause seizure. Then family history should include asking is there any family history of seizures. Social history should include whether the patient is workplace safety is important. If the patient is a manual worker in work and involved in construction and is doing job at the top of the buildings, the patient should change his or her job because not safe. So work safety should be established. We should all ask about alcohol use and recreational drug use as well in the history. I hope you like the video and please subscribe to the channel.